I'm going to talk on a very important topic that's about the update on management of hypertension. And I'm Dr. Kumudini Jayasinghe, specialist in internal medicine and working at National Hospital, Kandy. And in my outline that I will describe introduction, definition, and classification. Then I will come to the main part of my talk, the evaluation of hypertension, management, and also some special hypertensive situations. The references for this talk is mainly on the two guidelines. The one guideline is the ISH 2020 guideline, which is a very practical guideline, and also our national hypertension guidelines, which was actually done in last year with the NCD unit of the National Ministry of Health. Actually, this is the most single risk factor which is difficult to control. And 40 to 50% of hypertensives, their blood pressure is not under control. And this disease is usually asymptomatic. And until it becomes very severe or until they get complications. And this increases with very high cardiovascular mortality. About 7.5 million every year die from hypertensive related deaths. And as it is asymptomatic and causes many cardiovascular deaths, and it's called silent killer. And according to the available evidence, and one third of Sri Lankan adults are having high blood pressure. The classification is very simple. This is only primary hypertension. This is again called essential and secondary hypertension. The essential hypertension or primary is about 90%, and there's usually no underlying cause. But for the secondary hypertension, there's usually underlying etiology. Though there are no underlying etiology for the secondary hypertension, there are many risk factors which is associated with this primary hypertension. The family history, diabetes, dyslipidemia, obesity, and many more other risk factors, even the stress and the lack of physical activity. Diagnosis of hypertension is very easy by measuring the blood pressure. There are three methods of measuring the blood pressure. The clinic, or the other countries, they call it office blood pressure measurement, is what we commonly carry out our day-to-day practice. And there are two other out-of-office blood pressure measurements, either home blood pressure measurement or the ambulatory blood pressure measurement. I mean, what is best out of these is the ambulatory blood pressure measurement. However, this is not freely available for us. The definition of hypertension again is very important. So if you look at this chart, you can see this office blood pressure, office or clinic blood pressure is equal or more than 140/90. However, it's for the ambulatory blood pressure monitoring and the home blood pressure monitoring, it's lower than the office blood pressure value. So if the ambulatory blood pressure monitoring is 24 average, that is equal or more 130/80. And for the home blood pressure monitoring, it's equal or more 135/85. The classification of hypertension. We everyone know what is normal blood pressure. That is systolic less than 130 and the diastolic less than 85. And this new guideline, there are only two grades. There's a grade 1 and the grade 2. The grade 1 is systolic blood pressure 140 to 159 and the diastolic 90 to 99. And the grade 2 is very easy to remember, equal or more 160 to 100. And what is in between this normal and the grade 1 hypertension, that is called high normal blood pressure. This is important in the presence of high cardiovascular risk. There are two more terminology with regards to hypertension: masked hypertension and white coat hypertension. Masked hypertension is that at the clinic level, the blood pressure is normal. But if you check it out of office manuals, the blood pressure high. how do you actually suspect this condition? So you have a patient with a normal blood pressure at the clinic level, but they have the organ damage due to hypertension. For example, if you get a patient with the ECG showing left ventricular hypertrophy with a normal blood pressure, that you have to suspect whether this patient is having masked hypertension. In that situation, you need to arrange this out-of-office blood pressure monitoring. Then the white coat hypertension, that is in contrast to the masked hypertension, there they have the high blood pressure at the clinic level. However, when we check with the out-of-office, that's the blood pressure is normal. That you can suspect the situation when they have the high normal or the grade 1 hypertension, and also when they have no organ damage. So this is very important, correct blood pressure measurement. If you do not do this correctly, you can falsely diagnose this as a hypertension. So remember this to follow these steps, what I'm going to describe now. Actually, patients should be in a very comfortable situation, because there shouldn't be any pain or any distress, and there should be rested at least for 3 to 5 minutes before checking the blood pressure, and the patient should avoid taking any caffeine containing drinks, smoking, or should avoid exercise at least half an hour before the procedure, and should be seated on a chair, back supported, and feet should be on the ground and should not cross with each other. And then the blood pressure, the cuff, actually the ideal cuff should be choose according to the patient arm size, and should be used to the bare upper arm, and it should be at the level of the heart, not this blood pressure apparatus, remember this. And this validated BP apparatus should be used. And during this procedure, the patient as well as the examiner should not talk. That is again very important. And the first occasion that you have to take the blood pressure in the both arms. And for the subsequent measurement, that you have to take the arm with a higher reading and take another reading. And if there's a discrepancy between the first and the second, take the third measurement also, and discard the first one. Take the average of the last 2 readings as the blood pressure value. And remember that one reading alone that you cannot diagnose hypertension. So this is actually if you do not follow the correct the procedures, the technique, these are the actually blood pressure, the false readings that you can get. For example, if you do with the wrong cuff size, if it is too small, there will increase thrice of the blood pressure from this value. And if it is too large, there will be false reduction of the blood pressure value. And as a talk during the procedure, there will be rise of the blood pressure systolic and the diastolic to this much of level. So that's because of that's very important to do all these correct the maneuvers during the blood pressure measurement. So if the blood pressure is normal, that you need to measure the blood pressure according to the guideline. What they say is the recheck in 3 years, but you can decide how frequently you need to check your patient's blood pressure depending on their underlying the cardiovascular risk factors. And if the blood pressure is the high normal and the grade 1 range, that if the facilities are available, you can confirm it with the out-of-office blood pressure maneuvers. However, if that is not available, that you can confirm with the repeated clinic visits. At least 3-4 readings should be there for you to diagnose hypertension before that you confirm it as a hypertension. However, if the blood pressure is very high, if it is more than 160/100, you need to confirm it within days or weeks. If it is more than 180/110, you need to, if there are evidence of organ damage, you can start the treatment on the same day. Otherwise, within 1 or 2 days, you need to confirm that this is blood pressure is more than 180/110. So once you diagnose this patient is having hypertension, the evaluation of hypertension is very important with the detailed history, examination, and the relevant investigations to look for hypertension-mediated organ damage, that is organ damage due to hypertension, the associated cardiovascular risk factors, and the CV risk, and identify secondary causes. So how do you look for a presence of organ damage due to hypertension? Again, from the history, examination, and the relevant investigations, look for with regards to the heart, presence of left ventricular hypertrophy, heart failure, and the ischemic heart disease. And for the brain, it's TIA, ischemic or hemorrhagic stroke, or vascular dementia. For the kidneys, it's albuminuria and the chronic kidney disease. The blood vessels, it's a peripheral vascular disease. For the eyes, it's a hypertensive retinopathy grade 3 or 4. So next is the important thing, the CV risk factors and the CV risk. So usually more than 50% of hypertensive patients are having additional CV risk factors. Commonly, they have the metabolic syndrome, type 2 diabetes, dyslipidemia, and also high uric acid, which we commonly do not check actually. So because of that, it's very important to check the CV risk assessment in relevant patients and having hypertension. So also there are some other conditions which increases the cardiovascular risk, presence of chronic inflammatory disease such as rheumatoid arthritis, COPD, psychiatric disorders, psychosocial stressors as well. How to check the CV risk? This has already been discussed by Professor Jayasinghe. So I'm not going to discuss it in detail. So there are some conditions you don't have to check the CV risk. Established cardiovascular diseases like MI, strokes, diabetes, CKD stage 3 or above, and the presence of organ damage. These patients don't check the CV risk, already discussed by the Professor Mithananda as well. So other patients need CV risk calculation with a WHO risk calculator. I like this chart very much because it's very important one, because if you look at this, the table, because if you can see with the grade 2 hypertension, when the blood pressure is more than 160, 110, whatever the risk factors, they are having the very high risk, CV risk. So as with this presence of these diseases, which we have already discussed, irrespective of the blood pressure levels, their CV risk is high. So that means if one is having these disease conditions, or if their blood pressure is very high, that you need to start treatment to control this CV risk. So exclusion of the secondary causes. So practically, we cannot do this each and every hypertensive risk because it's not cost effective and also not feasible. So in which situation that you suspect that the patient is having secondary hypertension? In the presence of resistant hypertension. What is it? When the patient's blood pressure is not under control, with 3 antihypertensives with their maximum tolerated doses, one being a diuretic, then you call it resistant hypertension. Or if the blood pressure is very high, so in the first presentation itself, if the blood pressure is around more than systole more than 200 or diastole more than 110, that you have to suspect underlying secondary etiology. When young patient less than 35 years, you have to always suspect. Or a patient whose blood pressure previously well controlled, now all of a sudden becoming uncontrolled. And again, that you have to suspect. Or else, if they are having clinical signs of secondary causes, like in the Cushing's, acromegaly, thyroid diseases, that you can suspect. So again, the common causes are common. First, you have to consider the common secondary causes. Obstructive sleep apnea. Actually, this is very underdiagnosed. About 35% of Sri Lankans are actually snoring. Actually, and there's about 20% of them, according to a recent study done, are having the obstructive sleep apnea. And the chronic kidney disease, again, is very common. And the other thing is the Cone syndrome or primary hyperaldosteronism. Always suspect when the patient is having hypokalemia. The renal artery stenosis, again, is not uncommon because in the elderly it could be atherosclerosis, and in the younger patient could be due to fibromuscular dysplasia. But these causes actually rare. There are some other conditions that you have to think of. The drugs and substances induce hypertension. Always get this in your history as well. Sometimes we don't consider these things. For example, patients being on long-term NSAIDs and also the OCP. And it could be something like a amitriptyline, which are old patient who is having the uncontrolled hypertension. So think about these things. Actually, SNRIs, something duloxetine, and the venlafaxine, and these are again important. However, SSRI, fluoxetine, will not cause increased blood pressure. And the atypical antipsychotics, the steroids are common, important thing, because we day-to-day sometimes we start steroids for patients, and the erythropoietin and other the substances, alcohol and recreational drug, cocaine and the amphetamine. So think about these things and your patient when you take the history. So we have to do some basic investigations with regards to the hypertension, fasted blood sugar and the cholesterol and the lipid profile. If facilities are available to exclude other cardiovascular risk factors. Hemoglobin, why we are checking it? Because it could be a feature of the chronic kidney disease, or it could be polycythemia, which increases the blood pressure. And the 12-lead ECG, we are looking for the presence of left ventricular hypertrophy, previous ischemic heart disease changes, and also presence of atrial fibrillation due to hypertension. The urine protein and the UFR will give you an idea about the presence of renal diseases. And the serum creatinine, again, for the CKD and the renal impairment. And the electrolytes are very important. One thing is hypokalemia would be a reason for the secondary hypertensions, the cons and the renal artery stenosis or Cushing's. And the hyperkalemia could be due to the complication of CKD, or then the other thing is these two we have to start, because since most of the patients we are starting ACE inhibitor as well. So before treatment, that you have to get an idea about the renal functions and the electrolytes as well. So now we have to come to the main part, the important part of my talk, the treatment. It's mainly two parts: lifestyle changes we recommend in all the patients with hypertension, and the pharmacological treatment. Lifestyle changes: smoking cessation and the maintain a healthy weight and reduce salt intake, is usually less than 5 grams per day is recommended. What you have to tell patient is to not to add salt to the dishes. I mean, otherwise you can't just tell the less than 5 grams, patient will not understand. And also to avoid this, foods that contain salt, like pickles, the sauces, and also the fried rice and outside restaurant food. And advice on the eat healthy diet, fruits and vegetables, and the physical activity, and the reduce alcohol consumption. Actually, moderate alcohol consumption. What they have said like that, actually we better ask our patients to avoid alcohol consumption, because we cannot say that this amount to most of our patients. So this is actually I have taken from our national guidelines, this the flow chart. So once the patient is diagnosed as hypertension, so lifestyle recommendation is for all the patients. And if they're having grade 2 hypertension, and you have to start treatment immediately, that is systolic blood pressure more than 660 and diastolic more than 100. At the same time, if it is grade 1 hypertension, if they're having high cardiovascular risk in the presence of this disease condition, and also WHO risk calculation chart, if it is more than 20%, you have to start treatment immediately for this category. So immediate treatment is a grade 2 hypertension, and the grade 1 hypertension with high CV risk, you have to start treatment immediately. But for the grade 1 hypertension without high CV risk conditions. And then you can recommend lifestyle changes for 3 to 6 months before starting antihypertensives. Failing that, you can start. So this high normal blood pressure, that's blood pressure between 130 to 139 systole, risk along with the lifestyle changes of the other patients who advise on lifestyle changes and monitor blood pressure regularly. So in the pharmacotherapy, there are 3 first-line antihypertensive groups. The first group is ACE inhibitor ARB, which commonly causes RAS blockers. And these are the ACE inhibitor we commonly know. Drugs available for us in the hospital sector is enalapril and captopril. ARB is losartan potassium. Dihydropiridine calcium channel blockers, the amlodipine and the nifedipine SR. And the thiazide diuretics and the thiazide-like diuretic is other group. Thiazide diuretic available for us is a hydrochlorothiazide. Thiazide-like diuretics are available at the private sector, like indapamide and clothianidone. Remember, the beta blockers are no longer recommended as the initial therapy, but the beta blockers are very useful in certain conditions. For example, if they are having ischemic heart disease, chronic heart failure, or if they are having atrial fibrillation, or if they are in childbearing age, or if they are in pregnancy, that the beta blocker has a very good place. Drug treatment strategy, there are stepwise processes in the management. Let's discuss it. And the step 1, the low dose combination that I have given the letters, that A is the AC inhibitor or ARB and the C is the calcium channel blocker, but it could be something else as well. It could be thiazides as well, depending on your patient, that you can decide what to be started. So initially you can start in the lower dose. So other countries, they do the combination pill. In that situation, it's better. So if the blood pressure is not under control, the next step that you go for the dual full dose combination, that you can increase the doses. So it's again depending on your patient's blood pressure. So if it is not very high, that you can initially increase on the one drug, and the next visit that you assess the blood pressure and decide on the increase of the other drugs. But you go for the maximum tolerated doses of these 2. And the step 3, then you add the third one, that is the diuretic. So then that you increase the diuretic doses as well. But if the blood pressure is not under control at this moment, then the step 4 is the resistant hypertension. I hope that you could remember the resistant hypertension when there was maximum tolerated doses of 3 antihypertensives, 1 being a diuretic. So we have now resistant hypertension. At that moment, actually, you need to refer this patient to a specialist to investigate. And the drug which can start at this moment is spironolactone. But remember, if it is cons, that there may be problem on the diagnosis. So there are combinations. The thiazide is the RAS blocker, thiazide is the calcium channel blockers. RAS blockers with the calcium channel blocker. These calcium channel blockers usually written here is the dihydropyridine calcium channel blockers. But if what the guideline says is dihydropyridine calcium channel blockers are not available, that you can use the non-dihydropyridine calcium channel blockers like diltiazem or verapamil. Sometimes you can give the combination of the dihydropyridine calcium channel blockers with a beta blocker, because this can increases the heart rate, whereas this can reduce the heart rate. So remember, but you should not give the AC inhibitor or ARB together. Same as the 2 calcium channel blockers, don't give, as well as the beta blocker with the diltiazem or verapamil. So the choice of the initial antihypertensive depends on the underlying target organ damage or presence of comorbidities, the patient compliance, and the cost and the availability. Diabetes, we usually start with the AC inhibitor ARB, and the presence of again left ventricle hypertrophy, AC inhibitor or ARB. The microalbuminuria, stage 1 to 3 CKD, again the same. And if the CKD stage 4 and above, be careful about starting the ACE inhibitor ARB because there could be hyperkalemia. In that situation, you may start calcium channel blockers. The ischemic heart disease we have already discussed, the beta blockers, the ACE inhibitor other than that, OARB and the calcium channel blockers will be useful. And the heart failure, if it is chronic heart failure other than the ACE inhibitor ARB, diuretics is here is the, if it is symptomatic, loop diuretic, and otherwise mineralocorticoid receptor antagonist like spironolactones are useful, and the beta blockers in the chronic heart failure. Peripheral vascular diseases, remember to avoid beta blockers. In the pregnancy, the beta blockers, the labetalol is a drug of choice, and nifedipine and the methyl dopa, remember to avoid. There is a contraindicated in pregnancy ACE inhibitor or ARB, that is enalapril, losartan potassium, the captopril classes. So why this combination therapy is important? Because you can see with this study done, when you give the combination, there will be better control of the blood pressure than the doubling of the same drug, which you actually causes side effects, whatever the drug. So remember this to actually give the combination therapy where possible. So you cannot give the combination therapy in certain situation when the patient is very elderly patient, the start monotherapy, and or else if they are having the low risk grade 1 hypertension, you can start with the monotherapy, then up titrate and see. Otherwise, in all the other patients and the classes, try to give the combination therapy. So try to improve compliance by using once daily antihypertensive. Remember these amlodipine, enalapril, and losartan potassium are once daily antihypertensives. And use a single pill combination when affordable. Simplify the drug list. Actually, this is very, very important. Then you can improve the compliance of the patient. Prescribe considering the availability, cost, and affordability, especially in these days. Sometimes you cannot stick to the guidelines as well. So what is our target? So it's very easy with this new guideline. Target for all the patients, all the categories, less than 65, less than 30, 80. If it is above 65, you can keep it less than 140, 90. Again, in everybody, do not reduce the blood pressure less than 120, 70. That can cause actually increased mortality. So when the blood pressure is very high, do you admit all these patients? So before that, actually confirm this is as high blood pressure. So sometimes the patients are in pain, distress, make sure that they are not in pain or distress. Then check the blood pressure, that you will admit patients if they are having a hypertensive emergency. That is mean having the acute organ damage. The presence of acute stroke, acute heart failure, acute coronary syndrome, hypertensive encephalopathy, aortic dissection, or acute AKI, acute kidney injury. So then patient need IV antihypertensive. So admit these patients. Otherwise, just because they are having the high blood pressure, you don't need to admit them. What you need to do is you can do as like in other patients, you can check whether the presence of evaluation for the HMOD and the CVD risk and start treatment as outpatient, and you can review the patient even in 1 or 2 days later. So admission is not indicated if the patients are not having hypertensive emergency. The resistant hypertension, we have already discussed the definition. And when the patient's blood pressure is not under control, before that you label this as a resistant hypertension, you have to think of certain the specific situation. Exclude pseudo-resistant. That is whether you have, one thing is whether you have to check the blood pressure correctly. Another thing is the patient, whether the patient is having the white coat hypertension. Or are they compliant with your medication that you prescribe? And whether they have the other the risk factors like alcohol, high salt, or whether they are any kind of pain or distress. Always think about these things as well. Or else the drugs which I have mentioned previously. Think about these things, and before that you label this as a resistant hypertension. Then think about the common secondary causes and investigate rationally rather than arranging batteries of investigations at once. So when you refer a patient to a specialist, if you suspect secondary hypertension, hypertensive emergency, definitely you need to admit presence of advanced hypertensive retinopathy or new onset cardiovascular diseases or CKD. Hypertension is in young patients if you suspect white coat hypertension or masked hypertension or resistant hypertension. These are the conditions that you need to get the specialist opinion. The follow-up assessment, monitor patients in our setup every 1 to 3 months time, the response to the drug treatment, and also advise them on the lifestyle changes. And if their blood pressure is not under control, and especially in elderly, that you need to reassess them more frequently. In the elderly, you may have to check for the postural drop of blood pressure also, think about it. And ask about their drug compliance, very important. Most of the patients do not take, though you prescribe the medications. The reasons are actually multifactorial. Sometimes they cannot afford, they're not available, and they have not given enough instructions. So very important to discuss with the patient about their compliance. And annually, you can check for this CV risk assessment and also the presence of hypertension-mediated organ damage. To summarize, assess the cardiovascular risk and the hypertension-related organ damage in all the patients. So use guideline recommended combination therapy whenever possible. So look for common causes in uncontrolled hypertension and investigate rationally. And use affordable once daily medications to improve compliance of the patient. Just to again summarize with the values what you do. So if the blood pressure is more than 180, 120, think about whether the patient need admissions in the presence of hypertension emergency. And if it is more than or equal more than 160, 100, or in the presence of you need to start treatment immediately. If it is less than 160, 100, if it is high risk, that you start treatment immediately. Otherwise, that you can manage according to the guidelines that we have discussed. So thank you very much, your patience listening.